Hi, I'm Tari Turner, Director of the National COVID-19 Clinical Evidence Task Force and Associate Professor at Cochrane, Australia in the School of Public Health at Monash Uni. Welcome to TaskforceTV. I'm recording this today on the lands of the Boonwurrung people, and I pay my respects to their elders, past, present, emerging, and note that these lands are unceded. In this episode, we'll discuss the latest recommendations from the task force, particularly focusing on caring for people after COVID, what's also known as long COVID. And I'm delighted to be joined today by two wonderful guests, Dr. Samantha Chakraborty, who's Methods Chair of the Primary and Chronic Care Panel for the task force. She's a Senior Research Fellow at Monash Uni in the Department of General Practice. And also by Dr. Alistair Miller, a member of our Primary and Chronic Care Panel on the task force. Alistair is a respiratory and sleep physician at the Royal Melbourne Hospital and the Peter MacCallum Cancer Centre. Thank you both very much for joining me today. I'm going to come to you first, Alistair, and I'd love if you could just give us a bit of background. Essentially, we'd love to know the stories you'll be telling your grandchildren in 50 years' time about what it is you've been doing in treating people with COVID and what's it been like to try and treat a whole new disease.
Tari, I think it's been a real journey, I guess, over the last couple of years. We started out really knowing nothing at all and watching the stories and reading about the disease as it was progressing in other parts of the world, with sort of equal parts excitement and terror. And I always remember being in the physiology lab downstairs in the department here, talking about how many CPAP machines we needed to source so that we could provide care for people when our ICUs were overwhelmed. I always remember it as a really collaborative time, talking with colleagues both in Victoria and nationwide and internationally about their experience and how they were managing it. But fortunately, it never really came to that. We were never at the point where our ICUs were oversubscribed, and we didn't have to make the calls that people overseas did. But really, the really rapid change, I guess, in how we saw the disease, how we were treating it, and the incredible explosion of evidence as it came through, really meant that if you were away for a couple of weeks, everything had changed. We started off in the first wave really having no treatment at all except for supportive care, and it was all new. We're really starting the experience in Australia. But by the time the second wave came on, there was evidence out there for treatments, and really every subsequent wave there was new treatments in hospital initially, and then ultimately out of hospital. And so it's been extraordinary to be part of it. But I'm really glad where we are now rather than where we were 2 years ago.
I love that phrase, Alistair, the combination of excitement and terror. I think we've all experienced that in various ways over the last couple of years. You mentioned too how, the initial focus really, I guess, both of the research and of treatment was really around the acute management of COVID. And now happily we're able to move to the kind of more care after COVID space is getting more attention. And there's lots of different words that are used in that space, Alistair, and I'll come to you too, Sam. We talk about long COVID, we talk about post-COVID, there's post-acute COVID condition, there's a whole lot of stuff going on. What do we mean when we talk about that space?
Yeah, look, it's really hard, Tari, and I guess there are a few definitions. The WHO definition is the one that's most talked about, I guess, but there are others from other organisations, including the task force. And I guess we're talking about those people who don't follow a recovery trajectory from their acute illness. We know that the acute illness is really varied from person to person, and we're still learning why that is. But it's similar in the recovery. And so the vast majority of people will have recovered by 4 weeks after their acute illness, but there are a proportion of people who have symptoms at 4 weeks and some who persist to 3 months and beyond. And I guess it's really those people who have persisting symptoms, and particularly those who have a functional impact of those symptoms that we're talking about in this post-COVID or long COVID space. The WHO definition talks about 3 months after illness and symptoms lasting at least 2 months. But I think there is some grey in that, and certainly if you've been 2 months after your illness and you're still really unable to do anything because of your fatigue, then clearly there's something going on that isn't just the acute illness.
And I know that the primary and chronic care panel has covered both the acute care of, as you say, the vast majority of people who will be cared for with their acute COVID in the community, as well as that longer period. Sam, are there other things to think about in terms of the variations between those terms, or can we kind of talk about care after COVID as a more general framing? Anything else we should be thinking about there?
I think it's the way we've kind of approached it is it's changed actually over the last 2 years. So we first really started talking about this topic in 2020, when people first started describing their symptoms after the acute infection. And this term long COVID came about. And I think it's really great that we use this term long COVID because it's a consumer developed term. So this came out of consumers, many consumers from across the world. But because it refers to kind of any symptoms after the acute phase, which really is, from about 3-4 weeks onwards. Coming back to what Alistair was saying, we have some definitions around what's post-COVID condition. So the task force describes post-COVID condition as 12 weeks after the acute infection. And as Alistair also mentioned, it's where people have some sort of functional influence on their lives, impact on their lives. It is important to remember that symptoms can occur in that between phase, so between 4 weeks and 12 weeks. And what we really want is for patients and clinicians and caregivers to start approaching care at that stage and recovery at that stage, and not to wait until 12 weeks. And so I think that's the kind of the key thing that we want to emphasize is that we do have that acute phase of the illness. Like a lot of viruses, people can have post-viral symptoms, but for post-COVID condition or long COVID, these can occur between that 4-week and 12-week mark, or can continue after 12 weeks as well.
Sam, you've been involved with the COVID task force from the kind of evidence perspective for what feels like a very long time, and is a couple of years now. And I think that the space around the evidence is different for long COVID than it is for many of the other areas of the task force guidelines. Can you tell us just a bit from the evidence perspective, what do we know, what do we not know, what do we still need to know?
Gosh, a lot. I think probably a lot more that we need to know, although we do know a lot as well. So we've been, because our task force guidelines are focused on developing evidence-based recommendations for care, we focus quite specifically on identifying trials and treatments for care. But because this is an emerging condition, there's so much underlying stuff that we still yet to find out. And there's been, if anyone does a search for long COVID or post-COVID condition, there will be thousands and thousands of hits that you find. And so what we're really finding is that we've had to keep abreast of all of the other kind of emerging data about epidemiology, understanding the underlying pathology, potential prognosis, potential trajectories. And that data is still emerging to help us understand what we're actually talking about in terms of post-COVID condition. There are emerging studies also on treatment approaches, so mostly focusing on rehabilitation, but there are others as well. And there are some really interesting studies around systems and how to get people better access and appropriate access to treatment as well earlier. So there's lots of different types of work going on in this space.
It's exciting to see, actually. It does feel like there's about to be a wave of evidence that will help clinicians treat patients with this complex set of symptoms. Alistair, I'm aware that the Primary and Chronic Care Panel has come out with some recommendations recently, consensus-based primarily. What do you think are the key takeaways for clinicians who are dealing with patients after that acute phase of their illness?
I think that really the key parts of it, Tari, are about putting the patient at the centre of it all. As you said, while it really does feel like it's about to come, we don't have any specific pharmaceutical treatment recommendations for long COVID at this point. And so really it's about taking a symptom-based approach and using existing diagnostic algorithms for those symptoms as is appropriate for the patient at the time. And then utilising multidisciplinary rehab if there are symptoms of concern for that person. I think it's really challenging in primary care to tease out which symptoms are those ones that need thorough investigation and which ones can be watched. It's much easier for us in hospitals, having had that filter in the community. But I think it's incredibly challenging to have the time and space to be able to work out those really challenging decisions and diagnostic pathways.
Sam, anything to add in terms of the current taskforce guidance?
I think Alistair really did touch on it, and it's really about putting the patient at the centre and validating their experience. That's a key thing. The way this health system is designed is that patients have to seek out this care majority of the time. And so, when they're faced with, when they seek out that care and they receive really, considerate and patient-centered care and response, it really helps to drive that positive recovery-oriented approach. And we say that if a clinician's not familiar with or not comfortable with or confident with how to work with their patient, to do refer them on, because there are other options as well.
Alistair, it feels like there are still lots of questions in this space. And obviously we're hopeful that there'll be answers in the future, but what are the burning questions, do you think, from a clinical perspective? What are your colleagues asking about caring for patients in this after COVID context?
Yeah, look, I think there are still questions about mechanism. We still don't really have a great handle on why some people have terribly debilitating fatigue and some people don't. There's certainly much more basic science, I guess, information about changes in immune function and perhaps endocrine function, but we still don't have a great mechanistic bridge from there to the symptoms that we're seeing. I think it is a challenging space because there is quite a lot of non-academic literature on long COVID, and as Sam mentioned, long COVID was a term coined by consumers, and the forums in this space are immense, and there's a lot of discussion online in that way. And I think that the biggest challenge is trying to keep abreast of those things that are being discussed in those forums and having some way of responding, because there certainly are a number of miracle cures that are discussed in those forums that we simply don't have adequate evidence to talk about one way or the other. And I guess they're not without risk, like any sort of treatment. And so trying to manage that discussion and manage the expectations of patients when we don't have anything else to offer from a pharmaceutical point of view for them.
It's interesting, isn't it? That certainly parallels, again, what happened in the early phases around acute treatment for COVID
Absolutely.
too. And I'm very hopeful, Alistair, that I hope that the task force can speak into that space too as evidence emerges. So Sam, I'm looking at you. Bring us the good news. Are there trials in the pipeline? Is there research coming for long COVID that might speak into some of those conversations and bring some evidence to inform, as you were saying, Alistair, one way or another, whether those potential options might be effective? Yeah,
no, they definitely are. As I mentioned just before, there are lots of rehabilitation trials or trials on a variety of rehabilitation methods. The designs are quite different, but I think the quantity of the trials is quite great, and they're seemingly quite consistent. So I think once we get to the point where we've got sufficient consistent data, they'll be a good kind of will be at a good place to make evidence-based recommendations about rehabilitation approaches. There are also a number of other trials as well in psychological therapies, treating some of the individual symptoms. There are also studies around system approaches that work well for patients to help them access that care. And so there are quite a few different trials kind of in the pipeline, and research in general that I think altogether is helping us to form a better approach towards care. Although I might also mention that we do have a recommendation in the guideline for those medical cures that Alistair mentioned, to use them only in the context of research, please.
And I think that's a really great opportunity too, isn't it? That people should be trying those new and potentially effective treatments in the context of research so we can learn if they actually are. My favourite question to ask every person on Taskforce TV is the kind of genie in a bottle, magic wand, what one thing would you change to improve the care of people for COVID-19? If you had that one wish, one wave of a wand, what one thing would you look for?
I really want to say two things, Tari.
Everybody always does, Sam. Come on, people. All right, go on then. Two things.
Oh, golly. Okay, so my two things are better recording of diagnosis. So currently clinical software systems and Medicare recording could be improved, and that would just help us to understand, the actual burden of disease in Australia. It'll help for patients to it will help clinicians to monitor improvement or recovery over time, help to coordinate care, all of that. So recording. And then my second, ideally, like I said before, at the moment, people have to seek out healthcare. It would be great if there was a way to just check in with patients and their caregivers, just to check to ask if they've got any ongoing symptoms that are actually affecting their their daily function and capacity or work, and then putting them in contact with appropriate care.
A woman after my own heart. I'll let you have both, because you've covered off patient-centred care and data there. So, you're on a winner with me. Alistair, what would you ask for given one, or potentially apparently two waves of a wand?
Look, I think I can just leave. I completely agree that, the documentation is incredibly important. And I guess, from that point of acute infection going forward, understanding what people are going through, as things progress. My other thing, I guess, is a bit more mundane, and I guess it sort of speaks to the same question as Sam did, and that's about access. And there's simply not a funding structure that allows GPs to provide this care in a consistent and equitable way. And I think having a primary care service that was well funded to perform this kind of function, it's not particularly magic wand, but it doesn't seem to happen. But I think that's really crucial for something that potentially affects so many people, and so getting access to care is the only way that they can have.
You're absolutely right. It's the kind of the fundamentals of the system, the data, the diagnosis, and then the access to care. That would be vital. Thank you both very much for speaking with me today. I hope that all of our futures and the future of all people with long COVID is perhaps a little bit less terrifying and a little bit more exciting as we see the new evidence coming through and new recommendations from your panels. I hope everybody has enjoyed this conversation as much as I have. Please feel free to send us your questions and let us know what I can ask our experts about on your behalf. And I encourage you to share this episode of Taskforce TV with your colleagues, and look out for our next episode.